Yeah, hello everyone. Am I audible?
Yes,
Yes,
yes, yes.
yes, sir, audible.
Okay. Yeah, I think you can start the case. No? Started already.
Hello, sir. Sir, good evening, sir.
Yeah, good evening. Yeah, yeah.
Sir, can I
I think
start,
you can
sir?
start the case. No? Yeah, yeah, start the case.
Okay, sir. Sir, a 57-year-old male patient, Hindu right-handed, educated up to 10th class, hailing from Hadapsar, Pune, working as a chef. Admitted on 18th January, examined on 20 January, informant being himself and son, and are reliable. Now admitted with chief complaints of abdominal distensions in 7 months and giddiness and increased sleepiness since 3 days. So patient was apparently normal 7 months back. Then he started developing abdominal distension, which was insidious in onset. Initially felt as heaviness and fullness of abdomen, which has gradually progressed over the next months to a state where patient had difficulty in wearing clothes of all size. This abdominal distension was diffuse and symmetrical and changes with position. Not associated with any history of pain, constipation, or vomiting, or not associated with breathlessness, lying supine position, or exertion. This abdominal distension was also associated with subsequent development of painless swelling of bilateral lower limbs. So, sir, I am audible now, sir?
Yeah, you're audible.
Yes. So, abdominal distension was also associated with subsequent development of painless swelling of bilateral lower limbs. So, next page, sir. Sir, next page. Yes, sir. So, this abdominal distension was associated with subsequent development of painless swelling of bilateral lower limbs, which is insidious in onset. So initially involved only feet, which has gradually progressed up to the level of knees, with straps of slippers imprint on the swelling. Less in the morning and increases as the day progresses. So it is relieved on lying down with leg elevation, with no history of any redness or pain in the swelling. So this abdominal distension and leg swelling was not associated with any chest pain, palpitations, syncope, or decreased urine output, frothy urine, or periorbital edema. Patient also has yellowish discoloration of eyes, which was insidious in onset, initially noticed by his wife in the eyes, light yellow in color, which gradually progressed to the whole body and increased in intensity over the next 4 months to dark yellow in color. So this yellowish discoloration was associated with decreased appetite and nausea sensation. No history of any itching, pale colored or foul smelling stools, no history of any cola colored urine blood transfusions in the past or present. So with these complaints, patient was hospitalized elsewhere 2 months back. So and said that 3 liters of fluid was removed from his abdomen using needle, which was yellow in color, and OGD was done, and mentioned in procedure was done to avoid blood vomiting, which he couldn't remember, and started on medications which increase frequency of urination. And post which he has discharged, and his abdominal distension and pedal edema decreased, and he felt better and resumed his chef duties. But now, since 5 to 7 days, patient has started developing giddiness in the form of spinning sensation in the world around him and causing difficulty in ambulating. This giddiness was not associated with any postural variation, any ear pain, ringing sensation from ears, or any limb weakness or involuntary movements. Sun mentioned that a patient also had increased sleepiness during the daytime during the last 3 to 4 days. No history of any irrelevant talk or abnormal behavior. Next patient. Next page. Next. Sir, above. Sir, above, sir. Sir. No history of any needle prick injury, IV drug abuse, tattoo or high risk sexual behavior. No history of any skin lesion, oral ulcer, hair loss, or rash. No history of any increased urine output, increased water consumption, or increase in food intake. No history of any irrelevant involuntary movements or psychiatric abnormalities. No history of intake any complementary alternate medicine or herbal medicines. And no history of any blood vomiters, pain, abdomen and fever, rash, bleeding tendencies, petechia, and easy bruising. So past medical history, no history of any similar complaints in the past, not a diabetic hypertension or thyroid illness, not any known chronic major medical illness or surgical illness in the past. So should I continue, sir?
Yes, go ahead.
So personal history consumes both vegetarian and non-vegetarian, but has decreased appetite since last 10 days. So as chronic alcohol consumption since 30 years, daily drinks rum or whiskey 180 to 360 ml per day, which is equal to 4 to 8 standard drinks per day. With last alcohol intake 10 days back, which is 180 ml. So non-smoker, non-tobacco consumption or any other addiction, bowel and bladder habits regular, sleep habits were regular, but has increased sleepiness during since a day since the last 7 to 10 days. Has monogamous relationship and no history of any high risk sexual behavior. Drug history E is on medications which increase urine output and decrease heart rate. Family history is not significant. Summary. So 58-year-old chronic significant ethanol consumption with no other comorbidities or family history. Now presented with ascites icterus since last 6 months and altered sleep pattern and giddiness since last 7 days. With one past admission and 2 months back, with ascitic tapping and upper GI endoscopy and done. So probable system is involved is gastrointestinal system, and my provisional diagnosis is decompensated chronic liver disease likely due to ethanol consumption. And I would like to do examination to confirm the diagnosis.
Okay, go back to your first chief complaints, please.
Yes.
So what are the chief complaints?
Sir, abdominal distension since 7 months and giddiness and increased sleepiness since last 3 days.
Okay. Already mentioned in previous cases also in last few days that don't keep your primary chief complaint. Chief complaint means why patient has come to you. So currently, usually it will be because of more drowsiness and all. When you are
Yes.
mentioning HOPI, you can definitely start that patient was apparently all right 7 months ago, and history starts from 7 months before where he started having all these issues like that. So chief complaint should be
Okay, sir.
for which patient has come to your hospital, which are the recent events. Okay, so that's
Okay,
okay.
sir.
Okay, how was the abdominal distension?
Sir, it is symmetrical, sir. It is diffuse and symmetrical,
Mhm.
and changes with position and not associated with any history of pain, constipation, or vomiting. Now
Okay,
associated, not associated with any breathlessness, lying supine, or an exertion.
okay, go ahead.
And this abdominal distension was also associated with subsequent development of painless swelling of bilateral lower limbs. It was insidious
Okay,
in onset.
so what are the causes
Initial,
where you get first abdominal distension and then you get bilateral lower limb swelling?
sir, CLD ascites, constrictive pericarditis, or right heart failure, tricuspid regurgitation.
Yeah, CLD, okay, but CLD usually have both together, at least ascites as well as edema. That's
Yes, sir.
fine. Okay. Yeah. Constrictive pericarditis is right where you will have more of ascites first. Okay,
Yes,
then.
tricuspid regurgitation, right heart failure, restrictive
Mm.
cardiomyopathy.
Okay, next.
So, which initially involved only feet, which has gradually progressed up to the level of knees, with straps or slippers present on the swelling. Less in
Okay.
the morning and increases as the day progresses. It is relieved on lying down with leg elevation and no
Why
history
why
of any
why
redness
edema?
or
Why edema happens in CLD?
because of decreased oncotic pressure.
Okay. Okay.
So, there is no history of any redness or pain in the swelling. So this abdominal distension and leg swelling was not associated with any history of chest pain, palpitation, syncope, decreased urine output, frothy urine, or periorbital edema.
Yeah. Then.
Then patient also has a yellowish discoloration of eyes, which was insidious in onset, initially noticed by his wife in the eyes, and which is light yellow in color to start, which has gradually progressed to whole body and increased in intensity over the next 4 months to dark yellow in color.
That is when all these things happened.
Sir, it was on the first admission only, sir, 7 months back, along with
Yes.
ascites.
Okay. So what do you think? What happened?
Sir, liver, so it is because of all liver disease with, so it is decompensation, sir. It was initially compensation, now it has turned into decompensation.
Mm-hmm.
So over the next 4 months to dark yellow in color, this yellow discoloration is associated with decreased appetite and nausea sensation. No history of any itching, pale colored or foul smelling stools, no history of any cola colored urine or blood transfusion in the past or present.
Okay. Fine. Next.
Next patient. So with these complaints, patient was hospitalized elsewhere 2 months back.
Okay.
So and
Any
said
time.
that 3 liters of fluid was removed from his abdomen using needle,
Mm.
which was
Yeah.
yellow in color,
Yeah.
and OGD scopy was done.
Mm.
Mentioned him
But
that proceed.
never mentioned. Previously also you mentioned OGD. You should always mention full forms only. No short
Yes,
forms in exam. Okay.
yes, upper GI endoscopy was done.
Mm.
Mentioned him
Mm.
that this procedure was done to avoid blood vomiting, which he couldn't remember
Mhm.
the name of this,
Okay.
and
Was it
started
only
on
the
medication.
procedure? Was it only the endoscopy done, or some procedure was done with that?
So they have said that has mentioned him that some procedure was done to avoid blood vomiting,
Okay.
which he couldn't remember, and started on medications which increased the frequency of urination.
Okay.
Post which he was discharged and his abdominal distension and pedal edema decreased and felt better and resumed his chef duties.
Right. And now he
But
has
now
come
since
back. Mm.
5 to 7 days, patient has started developing giddiness
Mm.
in the form of spinning sensation of the world around him,
Mm.
causing difficulty in ambulating.
Mm.
So this
What
giddiness
is
was
it?
not associated with any postal variation or
Yeah.
any ear pain or ringing sensation from ears.
So what is this? What is this giddiness?
Sir, uh, because of encephalopathy or because of this, he has a feeling clumsiness. So he is complaining that as giddiness.
So is it giddiness or clumsiness?
So, according to patient complaints, he was saying that he is having giddiness, causing difficulty in ambulating. But there is no postal variation, no any ear pain, no any ringing sensation for ears.
What does happen in encephalopathy? Giddiness happens in encephalopathy, or what happens?
Sir, increased sleep pattern,
Mm.
irritability.
So
So it
is
can be
it
because of diuretics.
what can be because of diuretic?
The diuretics, sodium might have reduced, and then he has developed giddiness or postal hypotension because
Yeah,
of that
I
giddiness.
think I understand your point. You should mention your history in words of your patient only. But
Yes,
when you know that what patient is trying to say is different than what he is trying to say, well, basically, here what he is
yes,
having is mostly encephalopathy. That's what you are trying, hepatic encephalopathy. That's what you are trying to say ultimately, right?
yes, sir.
Yeah. So in that case, you can modify the words in a way that you can just ask patient कि चक्कर आ रहा है कि कमजोरी ज्यादा लग रहा है. He will just say कि नहीं सर के चक्कर ऐसा गोल गोल, whatever way he is doing it. So just
Mhm.
may explaining giddiness with encephalopathy is difficult. Maybe some alcohol related cerebellar symptoms, something else where um, posterior column symptoms. That way it can, maybe it is more explainable, but then it will not be sudden onset. Okay.
Yes, sir.
So
Yes,
explaining it with giddiness with encephalopathy is difficult. So try to modify your history in a way that it conveys what you are trying to say. Giddiness with encephalopathy is difficult to explain. That is the only thing that I'm trying to say. Okay. So that's okay.
yes,
But in exam, you can always uh, tell your patient in a way that you want to present. के अच्छा ऐसा नहीं ऐसा हो रहा होगा ना आपको ऐसा करके. You can just change his history in a way that it fits your criteria. I'm not telling you to lie or something, but patient को समझाना पड़ेगा कि this is what you are trying to say ऐसा करके. Okay.
Okay, sir.
Okay. So there is altered sleep pattern also. Now also irritability. All these things are there.
Yes, sir. So,
What-
Sun mentioned that patient has increased sleepiness during the daytime since last 3 to 4 days,
Okay. What else is there in
and
encephalopathy?
no history of any irrelevant talk or abnormal behavior.
Yeah. So why do you think patient is having these symptoms now?
So, because of sir, mostly because of diuretics can induce this hepatic encephalopathy. He was started on diuretics and might be dehydration, constipation,
So
but he doesn't have any.
so we never give diuretics to patients with cirrhosis, right? It can worsen the encephalopathy. That is
Yes,
what
yes.
you are trying to say. We should not give diuretics to patients with cirrhosis.
No, sir, we can give, but excessive diuretics we have to
Okay.
monitor his salt and input output and weight postal hypotension.
Yeah.
So one of the complication of
What are the precipitating factors for encephalopathy?
sir
Hepatic encephalopathy.
constipation, constipation, increased protein intake, upper GI bleed, sir hypokalemia and hyponatremia, metabolic alkalosis, which is because of diuretics and any infection.
Which infection?
Sir, spontaneous bacterial peritonitis or any bloodstream stress factor, any
Okay.
external stress factor, or
Out of this,
medications
which one is
increase
there
sleeping.
in your patient? What do you think? Which one has triggered this time?
The patient doesn't have any altered bowel bladder habits or no other things. Might be because of electrolyte abnormalities. With
Yeah.
was only positive factor is he's on diuretics. So
Yeah.
other no
So
other
here,
causes.
here that negative history is important. That what is the precipitating factor for this encephalopathy? Whether he has taken some alternative medicines or not. Here also,
Yes.
whether he has taken some, he has stopped alcohol. If, for example, he has stopped alcohol, but he started taking few days ago again, something has happened. Something new.
He
No,
has
no,
a
I'm just
history of
saying
yes,
all
sir.
these things needs to be ruled out here. Negative history becomes important here to rule out what is the cause of precipitating factor of this encephalopathy right now. Okay, fine.
Okay.
What next?
Sir, next I have taken the etiology
Past
history.
history, etiology history. Yeah, so that's okay. But did you ask for alternative medicine?
Yes, sir. No history of an intake of complementary alternate medicines or herbal medicines.
Hmm. Why do we ask that?
Sir, sometimes the patient got jaundice, icterus, then he takes these medications which can cause injury to heart, injury to liver.
Which medicines cause alternative? All alternative medicines, or what causes?
Uh, so yeah, is Ayurvedic medicines, herbal
All Ayurvedic
medicines.
medicine.
Not all, sir, but
What is there
uh,
in Ayurvedic medicines?
sir, these heavy metals,
Heavy
mercury.
metal. So that is important. Ayurvedic, everything is not bad. That
Yes,
patient
yes,
who take Ayurvedic medicines don't keep that negative impact in mind. There are
yes,
some substances which can cause it. Okay.
yes.
So
Heavy
okay.
metal.
Yeah. Uh, you know about alcohol intake, what's its significant alcohol intake, the amount of alcohol in each of the, starting from beer to whiskey, rum, everything. You know everything.
Yes,
I'm not
yes,
going
sir.
to ask, but you must know this in detail about alcohol, which contains how much, what is. So, what are the health hazards of alcohol intake?
Sir, injury to the liver and hepatitis, cirrhosis, or hepatocellular carcinoma. It can cause injury to the heart. Excessive binge alcohol drinking causes dilated cardiomyopathy. It can cause peripheral neuropathy. It can cause subacute combined myeloneuropathy, subacute combined degeneration of spinal cord, and it can lead to malnutrition because of deficiency of because of decreased food intake, and can cause malnutrition. Sir. Thiamine deficiency causing Wernicke's encephalopathy and then Korsakoff psychosis.
What is wet berry berries?
Sir, it is because of thiamine deficiency causing heart failure, sir.
Okay.
Heart failure with the
Only
preserved ejection fraction.
right. Only point was with that only that any question can come from right, left, anywhere. You should be
Yes,
just
sir.
able to mention it in a word, in a sentence or two at least, that you did well. So that is good. Okay.
Yes,
So yeah, alcohol related everything you should know. You must know.
yes.
What is binge alcohol? Binge alcohol drinking.
So binge alcohol drink is greater than 4 drinks in female or 5 drinks in male in 2 hours, sir.
Okay. Drink mean what do you mean by drinking? Standard drink you're saying or what?
Yes, sir. One standard drink. One standard drink equal to 14 grams of alcohol, sir.
Okay. And after suppose a patient, how much alcohol a patient should consume to develop CLD?
Sir, it is 80 to cirrhotic doses 80 grams of alcohol in case of males and 40 to 60 grams of alcohol in females for at least 10 years. He should consume. He or
Okay.
she should consume.
Okay. After consuming, how many percent will develop CLD?
Sir, it is 20 to 25. Sir, it is not clear. 15 to 20%. 15 to 20% of people only will be
Correct.
developing
Correct.
cirrhosis.
Yeah. Yeah. They said 20%. That's fine. Yeah. Correct. Okay. So that's what you should know everything about that alcohol. You can ask anything on what is standard drink, various
Yes,
alcohol content in various drinks, and also know all the percentages, everything about that.
yes,
Okay.
sir.
So
Is
yeah,
it
then go
important to
next.
have family history in this case?
Sir.
Uh, do you think family history has any importance in this case?
Yes, sir. Family history, some inherited disorders like hemochromatosis, Wilson's disease, and also family history of hepatitis B. If anything is there, it has passed through the generations.
Okay, go ahead. You know
Hepatitis.
the mechanism of encephalopathy,
Yes,
pathophysiology, why does it happen, how? Okay, so I'm not going to ask, but you should know what is the mechanism of portal hypertension, variceal bleed, all complications. Okay, so
yes,
we already discussed this 2 days ago, so I'm not going to ask in detail. So that's okay. You can go ahead.
yes. So, so next page. So,
So
sir, negative history. No history of any needle prick injury, IV drug abuse, tattooing, or high risk sexual behavior. No history of any skin lesions, oral ulcers, hair loss, or rash. No history of any increased urine output, increased water consumption, or increased food intake. So no history of any involuntary movements or psychiatric abnormalities. No history of any intake of complementary alternate medicines or herbal medicines. So
okay
this is
then.
etiological history. So then complication history, no history of any blood vomitus or pain abdomen or fever. No history of any rash, bleeding tendency, petechiae or easy bruising.
Okay,
And
then.
past medical history, no history of any similar complaints in the past. Not a diabetic, hypertensive, thyroid illness or no any other chronic medical illness or surgical illness in the past.
Yeah. Go ahead. Go ahead.
Uh, Personal history. So consumes both vegetarian and non-vegetarian, but has decreased appetite since last 10 days. So chronic alcohol consumption since 30 years. So daily drinks rum or whiskey, 180 to 360 ml per day, 4 to 8 standard drinks per day. With last alcohol intake 10 days back, which is 180 ml. So this can also be a precipitating factor for the hepatic encephalopathy. Last alcohol
Oh,
intake is 10 days back.
okay. Go ahead.
Sir, non-smoker, non-tobacco or other addictions, bowel and bladder habits regular, sleep was
Yeah.
regular and but it increased sleepiness during the daytime since last 7 to 10 days, has monogametous relationship with no history of any high-risk sexual behavior.
Why it
And
is
next,
important?
sir, sexually transmitted diseases like hepatitis B and hepatitis C can lead to cirrhosis,
Okay.
hepatitis and cirrhosis. So drug history, medications which increase, he is on medications which increase urine output and decrease heart rate. Family history is not significant.
Okay.
The summary. Next page. So 58-year-old with chronic significant ethanol consumption with no other comorbidities and significant family history. Now presented with ascites icterus since 3 months, altered sleep pattern and giddiness since 7 days. With one past admission 2 months back with which ascitic tapping and upper GI endoscopy was done. Probable system involved is gastrointestinal system, and my provisional diagnosis is decompensated chronic liver disease, likely due to ethanol consumption. And I would like to do examination to confirm the diagnosis.
Decompensated in form of?
So ascites, icterus, and hepatic encephalopathy.
That is what you should mention in summary also.
Okay, sir.
Yeah. Go ahead.
So examination.
Anything else, Akif?
Yeah, I think it's fine, sir. For an examination.
Okay.
As I
So
think
patient
you
cons.
cannot tell in that history. Somebody only on examination. There will be that abdomen distension.
Okay, sir.
Because icterus, during summary, icterus and this ascites can, I think after the examination part, we can say in that final diagnosis.
Okay, sir. Abdominal distension.
Abdomen distension, you can say. Only say I'm saying this ascites and icterus. That you have to mention in your final diagnosis.
Yeah,
I
so
think
as of
in the
now, at the
summary.
end of history, you should mention like patient is having abdominal distension and icterus, and
Yes.
not like ascites. Ascites you will know when you
Correct,
examine the
correct.
patient.
Yes.
Okay, sir.
Go ahead.
So examination part. So patient conscious, coherent, cooperative, obeys all commands, lies supine comfortably. Weight is 82 kg, height is 167 centimeters. The waist circumference is 97 centimeters, and temperature is 98.7. So BP is 120 by 70, or right hand in supine at right hand in supine position at the level of heart, and left hand is 114 by 70 with no significant postural drop. The pulse is
So
64 beats per minute.
what is significant postural drop?
Sir, systolic blood pressure dropped by greater than 20 mmHg and diastolic by greater than 10 mmHg.
Okay, like that's after how much duration? Yes.
Sir, it is checked at 1 minute and 3 minutes after standing, sir. So it is generally after 1 minute, sir. We check it 1
So
minute after
is
standing.
it from sitting to standing or supine to standing?
Or
Sir, it is from supine to standing.
Correct, correct. Okay. Yeah, okay, go ahead.
So pulse is 64 beats per minute, regular, normal rhythm, volume and character, with no radio-radial delay, no radio-femoral delay, with no vessel wall thickening, and all peripheral pulses felt. And respiratory rate is 17 cycles per minute, regular, abdominothoracic type. JVP is 3 centimeters above the sternal line, with no normal respiratory variation and hepatojugular reflex. Next, please. So pallor is present.
GVP, what does it tell you?
Sir, JVP is normal, sir.
Okay.
JVP
And
is
what was the abdominal jugular reflex?
sir, with normal abdominojugular reflex, sir. With it's normal abdominal. It was
Normal
only one.
abdominal jugular reflex.
Sir, on compression with stress stance on the epigastrium or abdomen, so JVP would be rising 1 to up to 3 centimeters, and it would fall within 5 cardiac cycles, sir. If it is persistent beyond 5 cardiac cycles, or if it is raised beyond 3 centimeters, it is significant. It is positive abdojugular reflex, which indicates left ventricular dysfunction, imminent left ventricular dysfunction.
Okay.
But is it required in this case? You have to mention this abdominal jugular reflex in JVP now. For this case, are you suspecting cardiac cause based on your history?
No, sir. No, not cardiac.
Okay. So any gastro or hepatology condition which can lead to your positive abdominal jugular reflex.
Sir, in case of constrictive pericarditis causing ascites, there will be positive abdojugular reflex.
Do you think that is the case right now?
No, sir. No.
Based on your history?
No, sir.
That's what I.
Yes,
So I just want to know you can just mention JVP was normal with normal respiratory variation or something. But I don't think you need to mention hepatojugular reflex as such. Doesn't have any significance to your case pertaining to your business.
Okay, sir.
So it varies case by case. Suppose you are a cardiac case, then definitely you have to mention. Even if JP is normal, then you can mention that hepatojugular reflex also checked and it was negative or absent.
Okay, sir.
Because sometimes the discussion can go exclusively to that. So if you are confident, then it's better. Okay. Anyways, you have answered all the questions. For remaining people,
Yes.
I'm saying. Suppose you are not very confident in hepatojugular reflex, don't try to avoid those things.
Yes, sir.
Yeah. Okay. Okay.
Pallor present, mild at palpebral conjunctiva, at the examine at palpebral conjunctiva. So edema present up to the level of ankle joint with grade
Mild at
2.
palpebral conjunctiva. What is moderate and severe at palpebral conjunctiva?
If it is present only at palpebral conjunctiva, it is mild. If it is present in pallor at oral mucosa and nail folds, it is moderate. And if it is present, if the palmar creases are absent, then it is severe. The grading.
So mild and present only at palpebral conjunctiva. That is what you are trying to say. Okay.
Yes, sir. Yes. If it is present at the other sites also, we'll consider moderate and severe.
Mm-hmm. And when it
So we
is
should.
severe, what
Yes, sir.
hemoglobin do you expect for this patient? What is severe?
Sir, if it is less than less than 7 gram per deciliter.
Okay. Okay, go ahead.
Yes. So edema present up to the level of ankle joint, grade 2 with pitting up to 4 mm depression with recoiling in seconds at medial, examine at medial malleolus. So icterus present
Can
seen
you say
in
it again?
sclera and
Edema? Edema, can you present again?
present up to the level of ankle joint. It is grade 2 with pitting up to 4 mm depression and recoiling in seconds at medial malleolus.
Okay.
Icterus is present seen in sclera and bulbar conjunctiva, examine bright light. No cyanosis clubbing and no lymphadenopathy, examined axillary and cervical group of lymph nodes.
No,
Head to toe
don't mention
examination.
that. Why have you mentioned only cervical and axillary?
Okay, sir.
If there is no lymphadenopathy, just say no lymphadenopathy. Don't go to.
Okay. Okay,
So
sir.
will you expect a cervical lymphadenopathy in this case?
Sir, any hepatocellular malignancy or any other conditions?
Okay. So that will go only to cervical
No,
or
but going
axillary
to
or any
cervical
other
lymph
lymph
node
nodes.
from liver is it common?
No, sir, not common.
Yeah, so you don't expect cervical lymphadenopathy.
Yes.
If it is there, you mention. If not there, just mention that there is no
Said no
lymphadenopathy.
lymphadenopathy.
Okay, sir.
See, now it got diverted. No? Your discussion could have went into hepatocellular carcinoma, how it present, everything.
Okay, sir. Okay.
So lymphadenopathy on general examination, we are supposing that you have examined all the lymph nodes. So if there is no lymph node, so no lymphadenopathy. That will be okay.
Okay, sir.
Okay. Yeah. Okay.
Head to toe examination, parotid swelling is seen, temporal hollowing, spider nevi is seen, gynecomastia, and loss of axillary and pubic hair. With no peripheral signs of TB or HIV seen.
You know the other
Abdominal
causes of
examination.
spider nevi?
Sir?
Spider nevi, other causes, do you know?
Sir, it is seen in third trimester of pregnancy. It is also seen in when the patient is taking drugs like sorafenib and
Which drug
ocpills.
you said?
Sir, the sorafenib, hepatocellular cancer treatment.
Okay. 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 That's all, and no other causes.
Sir, in OC pills, oral contraceptive pills, and conditions which
all this you are saying about the peripheral stigmata of liver disease.
yes, sir.
Each thing, now you should know the causes. They can ask you that. Okay, each thing you should know at least 4 to 5 causes.
Okay, sir. Okay.
Okay, so go home, just read that also. Okay? Each part of each peripheral stigmata, like parotid swelling, spider nevi. They can ask you causes also, other causes of that. Can be some people are very fond of this, asking this peripheral stigmata of liver disease.
Okay, sir.
And palmar erythema. You know the other cause of palmar erythema?
Sir, polycythemia vera or
Only one?
increased.
Any other?
Sir, it What is it? So it can be also secondary causes of raised hemoglobin, like smoking or other hyper smoking and uh, other causes which raise the hemoglobin.
Okay. Okay, just go and read that also. Okay. Everything, every
Okay.
stigmata, you should know 5 causes, and you should not get
Okay.
stuck here. Okay. So they may ask you, definitely CLD case, no. Generally, your case is very classical. They may not have much things to ask in your history because you are presented quite well. So
Yes.
then they will try to find the reasons where they can ask you questions. So all this also you should know. And if you're at a late off, they'll go to the next examination, abdominal examination.
Okay. Sir.
Differential diagnosis of spider nevi.
Um, sir, any different? So venous star.
Yeah, there are also cherry red spot. There are some things are there. So
Yes, sir.
just try to read them and how to differentiate between those. Okay,
Sir,
that is also.
you we use a dioscopy and compress at the central arteriole, and these capillaries disappear.
Yeah, yeah. One more thing is in general examination,
So,
it is not compulsory to say Jackal first and then only you go from head to toe. Basically, when you are looking general examination, you are looking patient from head to toe and you are
yes,
explaining here it is there, it is not there, here it is there, it is not there, right? So you can just
yes,
start with there is pallor, there is no there is pallor but no icterus. Then there is if you come to the parotid swelling is there, then you come to the chest, so there is spider nevi present or not, like that. So you don't need to mention that पहले तुमने anemia ही बोलोगे, then you will say about edema only, then you will say about icterus only, and then lymphadenopathy only, testicular swelling only, and then suddenly you will come back to again head to toe examination. It is usually a part of head to toe examination only, everything that you are stigmata, everything that whatever you are trying to say, no, they all are part
yes.
of your examination, head to toe examination only. So for
Mm.
a better visualization, if you can just start from head to toe. Alopecia is there, icterus as well as pallor is there. Pallor is mild. Then you go to parotid swelling is present. There is no lymphadenopathy, but spider nevi are present. On abdomen, whatever there is testicular atrophy or no atrophy or whatever, you can just go up to down and start mentioning your positive as well as important negative findings. Okay, you don't need to keep it as a separate topics only. Check all first only. Once you finish your vitals, it is head to toe examination basically. Essentially, that is what you are trying to say. Okay. So you can just mention
Okay.
from head to toe also.
Yes, sir.
Okay.
So abdomen examination. Patient examined in supine and standing position with knees and hip flex, with the thorax and abdomen exposed up to the level of mid thigh.
Yeah, we can see all that. I mean, when patient is lying in front of you, that's okay. If somebody asks you mention about these things, and otherwise, okay, go ahead.
Yes. So inspection, abdomen appears globular and symmetrical. Flanks appear full. Umbilicus is in midline. All quadrants of abdomen move equally with respiration. No any dilated veins, scars, sinuses, or pulsations. Hernial orifices
Umbilicus
and
is,
scrotals look. Sir?
umbilicus is inverted
Midline
or
and flat.
flat, or what type of umbilicus is there?
So midline flat, sir.
Okay, go ahead. Go
And
ahead.
then hernial orifice and scrotum looks clear. And palpation, abdominal girth is 97 centimeters. Spino-umbilical distance is equal on both sides. And superficial palpation, no warmth or tenderness and no guarding or rigidity present. The next page.
What if spine umbilical distance is not similar on both sides?
Sir, it can be because of any mass in the right hypochondrium or left hypochondrium. This will be leading to increased distance in the right or left.
Okay.
So deep palpation, superficial palpation, no warmth or tenderness and no guarding or rigidity. Deep palpation, liver could not be palpable and spleen could not be palpable. Percussion, shifting dullness elicited, horseshoe dullness present, no fluid thrill. Liver illness, upper border at fifth intercostal space in the midclavicular line, and lower border could not be appreciated. Trops percussion is dull. Top space percussion is dull. So auscultation, bowel cells heard, no venous sum or arterial bruit.
So why drop space is dull here?
So it is because of splenomegaly.
But you said there is no splenomegaly, right? It is not palpable.
Spleen is not, sir, because of ascites, spleen could not be, splenic tip cannot be
So there is
approachable.
no splenomegaly because of ascites. The drop space is dull.
So because of ascites, yes, sir.
Drop space. Where is drop space?
Sir, it is present in the, sir, it is a semilunar space. So upper border is 6 intercostal space and lower border is lower costal margin, and laterally it is mid
So
axillary,
ascites is
anterior
present
axillary.
above lower costal margin in the chest, right?
Yes.
Okay, just read it once, please.
Yes, sir. So auscultation, bowel sounds heard, no venous or arterial bruit. Per rectal examination is fecal state present, no hemorrhoid, skin tag, or any sinuses present. So other system examination, cardiovascular system S1, S2 heard, respiratory system, right infra-axillary and inframammary air entry is decreased, and CNS higher mental functions are normal. Tendon reflex is present. Sensory examination is normal and bilateral plantar flexor.
Higher mental function is normal. Then
Yes, the tendon reflexes are present. Sensory examination is normal and bilateral plantars are flexor.
did you check for flaps, flapping
Yes, sir.
tremors?
Flaps are present, sir. Flapping
कहाँ लिखा है?
tremors are present. Sir, not written. Sorry, forgot.
Okay. What about posterior column sensations?
So not checked, sir.
You written a sensory examination normal. You have checked.
Sir, sensory examination.
What
Yes,
comes
oh,
in sensory examination?
sir, fine touch, crude touch, temperature, vibration, and position sense.
Yeah, and out of these, which are posterior column?
So it is vibration and position sense are posterior column function.
You have checked, no? Why
Yes,
it is
sir.
important here?
Sir, it is because alcohol can cause subacute combined degeneration of spinal cord, which affects the
Cerebellar
posterior
symptoms,
column.
anything?
Yes, it can. No, any cerebellar.
Did you mention?
No, sir, not mentioned.
So you have to see the patient as whole. Now, once you know that it is liver, you should not focus only on liver. Okay.
Yes.
Some things are important. So this you should have. I think. I mean, in the rush of the exam also you might forget. So I'm trying to tell you again. Don't forget these things. Okay.
Yes. Yes.
Okay.
So
next page.
Yeah, one thing. What can be the cause of tremors in your patient?
Sir?
What can be the cause of tremors in your case, in your patient?
Sir, most likely is alcoholic hepatic encephalopathy, sir.
Any
So
other
that is
reason
flapping
for
tremor.
the tremors?
Any other tremors?
So it can be because of alcohol withdrawal also, sir.
Yeah, okay.
Then
Good,
what
good.
kind of
I just
tremors
want to
you will
ask
have?
that only.
Sir?
Okay, go ahead.
Yes. So my diagnosis is after examination. So 67 years old male with significant ethanol consumption. It is decompensated chronic parenchymal liver disease in the form of icterus ascites encephalopathy, stage 2 and type 3, with signs of portal hypertension like ascites, and with no evidence of acute kidney injury or SBP, or with hemodynamic stability maintained.
How did you check for acute kidney injury is not there?
Sir, based upon urine output, his urine output was normal.
How much was it?
So I have not measured, sir, but he says that it is normal. No any decreased urine output complaints.
Can you define acute kidney injury?
So rise in creatine by greater than 0.3 milligram for over 48 hours.
Okay.
Okay, sir. Sir, over, sir, presentation.
Yeah. So, what is the alcohol use disorder? Is your patient alcoholic?
Yes, sir, my patient is alcoholic.
Okay, my patient has alcohol use disorder. Don't try to use such words, alcoholic
Yeah,
and all.
last time we discussed that the terms are like using alcoholic is not that suggestible now. The terms has changed now. You should
Yes,
call
That was a
alcoholic
trap actually. I mean,
only when the person is dependent. That is based on Kagem audit score. When you collected the Kagem audit score, then only certain meets certain criteria, then only you have to say alcoholic. Otherwise, it is alcohol use disorder. How much ever chronic it is because of alcohol intake.
sir.
How much ever chronic the disease is, you have to use alcohol use disorder. That's not
Yes.
alcoholic.
Okay, sir.
Okay.
Okay,
Please make a note. These are new terms, so this might be fancy in asking an exam.
okay, sir.
Okay.
did you attend day before yesterday's class of CLD?
Uh, no, sir. I have
You
not.
should have, because same cases were going to be discussed. No, similar questions would have come to you also. Okay.
Yes, I will see today, sir. Yes.
Okay. Uh, so how will you manage?
Sir, first I would like to confirm my diagnosis by doing a sonography, and if ascites, and then I would see the echo texture of liver and any collaterals present, portal vein diameter and portal vein Doppler and spleen. So if and I would do a diagnostic tap to see the ascitic fluid, not routine count, cell cytology, and culture to check for any SBP or to confirm to see the SAC, to measure the SAC. So serum albumin ascitic gradient. So
What
if
is?
based on
Yeah,
sir,
yeah.
Is
Go ahead.
this patient already
sir,
diagnosed the chronic liver disease previously?
sir, in 2 months back, he was been said that he has liver problem, and he was done OGD and started on diuretics
Okay, okay,
and beta blockers.
okay. So they might have done acidic fluid tapping, right?
Yes, sir, but he doesn't have any details of it with him.
Okay. So you want to do again? Is it like and already in a case of already diagnosed chronic liver disease ascites, do you do routinely acid fluid analysis in every admission?
No, sir, unless it is a sudden increase in size or patient has complications like SBP or hepatorenal syndrome or hepatic encephalopathy, then we can do. The patient now
Okay.
presented with hepatic encephalopathy. To rule out any SBP, we can do ascitic fluid
Okay.
general
So
examination
whenever
and
you're suspecting
complications.
SBP, you're suspecting some complications. Every time, like not for diagnosing. So Agonal not needed repeatedly. But whenever a
Yes.
patient admitted, they were to do analysis for ruling out SBP.
Yes.
Okay. So what is SBP?
Sir, it is spontaneous bacterial peritonitis, sir. So it
Ah,
is
how do
diagnosed, sir.
how do you confirm it?
So we do ascitic routine and cell count and color. So if the cells are greater than 500 or
Okay.
out of which neutrophils should be greater than 250 and mono single organism should be grown on the culture.
Good. Good. Okay. So do you give prophylaxis to this patient?
Yes, sir. If once a patient has been, so it can be short-term prophylaxis or long-term prophylaxis. So short-term
Okay.
prophylaxis is generally given for 7 days if the patient has upper GI bleed. Or
Okay.
long-term prophylaxis is given when the patient is having a history of SBP or his ascitic protein is less than protein is less than 1.5 grams or in child pox C.
Okay. Okay. Good. Good. That's it. Okay. Fine. So what else do you do for management of this case? What
So
about encephalopathy? That is main patient having encephalopathy. Right? What is the grade of encephalopathy of this patient?
grade 2, sir.
How do you say grade 2?
Sir, it is West Haven's grading. So grade 2 is the patients having flaps. We would say it as grade 2. Grade 1 is altered sleep pattern. Grade 2 is patient having flaps. Grade 3 is increased sleepiness. Grade 4 is patient is in
Okay.
coma.
Okay. So how do you manage encephalopathy?
Sir, I would sir, ensure that the patient's bowel is open 2 to 3 times per day, and I would identify the precipitating factor. So in this case, the patient, because of alcohol intake 10 days back, or because of diuretics, the patient might be going encephalopathy. So,
Okay.
I would ask the stop the diuretics temporarily, and avoid alcohol. Ask him to stop alcohol, and then so ensure that bowel is open 3 to 4 times a day. And I would add diuretics, uh, rifaximin,
Okay.
and other not proven things like L-ornithine and L-aspartase can be given to the patient.
What are proven medication for encephalopathy?
So only the rifagut and lactose syrup lactulose, and bowel open with enemas 2 to 3 times a day, and potassium in the range of 4 to 4.5.
Only lactulose and rifaximin, not rifagot. Don't say trade names. Rifaximin.
Yes, rifaximin. Yes.
Okay. How does lactulose help?
So lactulose binds with lactulose helps in elimination of the ammonia. Sir. It prevents absorption of ammonia in the distal gut.
Okay. Okay. Then
Sir,
how
it
does
also helps
hypokalemia?
in.
How does hypokalemia? What are triggers encephalopathy? As you said, alcohol,
Sir, yes.
infection.
So what
Most common
it is,
precipitants.
sir.
Most common precipitants of encephalopathy are
Sir, most common is constipation or increased protein intake, sudden increase in protein intake, or upper GI bleed, infections, SBP, and diuretics, metabolic causing
is it
hyponatremia,
proven most high protein intake triggers encephalopathy?
So not proven, sir, but sudden
Don't put
sudden
it
increase
in first place. This might it can be it can but it's not that's main common most commonly bleed and infection.
yes, bleeding.
Electrolyte imbalance.
Yes,
These are three things you take first. Okay.
and also some sedative drugs like when the patient takes lorazepam or other benzodiazepines or other drugs can also cause precipitation of this hepatic encephalopathy.
Can you give lorazepam in patient with liver injury?
So because of alcohol, he might be started on medications. So
Can you give
benzodiazepine.
uh, lorazepam in patient with liver injury, acute liver injury?
Uh,
What are hepatoprotective benzodiazepines? The steroid ones.
yes, okay. Sir.
Okay. So I did not I could not attend initial first half an hour. Is the patient having a particular like acute liver failure or acute and chronic liver failure? Anything? Is the patient meeting the criteria?
Uh, uh, no, not meeting the criteria of acute liver failure, sir.
What is acute liver
So,
failure?
sir, it is raise in bilirubin by greater than it is icterus and coagulopathy. So followed by occurring encephalopathy within 7 days. Sir. Within 7 days, we label it as hyperacute, and then within 28 days, it is labeled as acute. Within 28 days, it is labeled as acute liver failure.
Okay. What is acute and chronic liver failure?
Sir, acute on chronic liver failure. Uh, Sir, there are two definitions, sir. One is ASLD definition, which says that the patient already a known case of chronic liver disease, having jaundice and icterus and icterus and coagulopathy, within 1 month developing this ascites or encephalopathy.
Jaundice and coagulopathy complicating the ascites and encephalopathy within 4 weeks.
Yes, yes.
This case might be acute and chronic liver injury, but not liver failure, most probably. Acute insulin is because of alcohol, current repeated alcohol intake.
Yes, sir.
Okay. Do you want to rule out any other causes apart from alcohol in this patient?
Sir, in infections, sir, hepatitis
Any?
B and hepatitis C.
Okay. If the patient is negative with hepatitis B, HbS agent, HCV, do you still think viral hepatitis could be the cause?
So sometimes in window period of hepatitis B can be cause.
Okay.
No, sir. No other causes. No other cause. There are
Okay.
two causes which are known, commonly known, sir, to cause hepatitis and cirrhosis.
Sometimes, if the patient is not with significant alcohol intake, you may have to search for other. There is a term called occult hepatitis B. In such cases, hepatitis HbS agent might be negative, but still you have to search for hepatitis B or DNA or some other tests. But that depends in area. This patient is definitely significant alcohol. Alcohol itself is enough to him to cause this much liver damage.
Yes, sir.
Okay. Dr. Deep, anything else?
Sir?
Hello?
Yes, sir. Yes.
Dr. Deep, is there? I think no one is.
Yeah, I was busy actually.
Okay,
Sorry.
okay.
Go ahead. Go ahead. Yeah.
Please discuss, sir, anything else.
So, regarding your history and summary, I think your history was well. Questions and answers you had given, negative history was also quite concise. So that's okay. That was good. You were able to give answers of whatever questions were being asked. So that is what is important.
Yes, sir.
Uh, if you mention something and you don't know the answer, that is bad. So if anything was asked, you were able to give answers. So
Yes.
only mention those things where you are confident that you, if further questions asked, you can give at least one or two answers, first one or two answers. So that you did well. Otherwise, CLD is a common topic. You will definitely get this case most probably in your exam, and this simple basics question only will be asked pathophysiology and all these things. So that you must make sure that you know. Okay. Last
Yes, sir.
part I could not actually hear the treatment portion, but I think you must be knowing those things. So that's okay.
Yeah, I think you prepared well.
Yeah.
Yes.
Okay.
You know
Nothing
what
else
is
from my side.
refractory ascites and what is refractory ascites?
Sir, refractory ascites is using a maximum doses or diuretics or tolerated dose of diuretics with salt restriction, unable to mobilize the ascitic fluid or unable to prevent the reappearance of ascites.
What is the maximum dose of diuretics?
Spironolactone is 160 mg, 400 mg, and loop diuretics is 160 mg. Sir.
Okay.
Yeah.
So you
Loop
this part
diuretics
of
specifically you should say. It's furosemide is
yeah,
160
that's
mg,
what
not all loop diuretics.
Yes, sir. Told
Mention that
whether
exactly.
each will take a
Mm.
different dose.
You know alcohol withdrawal? You have read about alcohol withdrawal
Uh,
because your patient was chronic. He used to consume alcohol daily. Na? Now, since 10 days, I think he has not taken alcohol.
yes, sir.
So, there was no symptoms of alcohol withdrawal in him. Do you know about alcohol withdrawal? Because you're in this case, na, they can also ask you about alcohol withdrawal, everything. So, how the symptoms develop. During each phase, there are first symptoms. Na? You remember that? In first 6 hours,
Yes,
there
sir.
will be one symptoms. Up to 12 hours, one symptoms will be there. 12 to 24 hours.
Yes, sir. First 6 hours,
Tremors,
the patient would be.
tremors in this case may lead you to questioning about alcohol withdrawal actually, than encephalopathy.
Yes, sir. Okay, sir.
Yeah. I think you're telling.
Sir?
I think you're answering about alcohol withdrawal, right?
Sir, alcohol withdrawal is seen in 4 stages. Sir, initially patient will be having within first 6 hours there will be irritability, and sympathetic activity will be set. In the second stage, they will be having uh, RUM fits. In that would be up to 24 hours, and in up to 72 hours, we get a delirium tremens. And so like not prepared for it. I have to read.
Okay.
Yeah, okay. You can read about that. Delirium tremens, they can ask you.
Yes.
The alcohol withdrawal is also. Since now, when it will be asked, when you are asking all the questions, so the only question then left will be the on alcohol withdrawal, where they can focus only on that also.
Okay, sir.
So just read about everything, withdrawal stages, the management of alcohol withdrawal also. Okay.
Yes.
Refractory ascites is
And
two types.
well,
Diuretic resistant and diuretic non-response.
Sir, diuretic resistant ascites is after giving maximum diuretics, the patient unable to mobilize or think. Diuretic
Another thing is complicating actually. We can't give much diuretic because of some complications like electrolyte imbalance or something, some other complications.
So that is diuretic intractable.
Yeah, intractable. Yeah.
Yes, sir.
No, these terms we should know.
Yes.
yeah, and one last question. Supposing this patient had a INR of 2.5.
Yes, sir.
And the patient has a gross ascites, and you want to know the cause of it. Will you do ascitic tapping?
So generally INR greater than 1.5 is we have to give FFP.
Are you sure?
That greater than 2.5 we have to give FFP, sir. Greater than 2.5 platelets less than 30,000 we have to give FFP before doing ascitic tapping.
Okay. So, see, as far as I remember, the INR is never a contraindication for ascitic tapping.
It's not definitely contraindicated. It's a relative contraindication. Still you can
so it's not absolute contraindication.
Yeah.
Still, if you want to evaluate, always you can do, I think.
INR won't stop you to do tapping. Yes.
Okay.
So how much of tapping you can do per sitting? Do you know about that? How much of ascitic fluid can you remove in single sitting?
So maximum of 5 liters we can remove with albumin coverage, sir. 8 grams per 1 liter of alcohol removed.
You sure? For suppose you are removing only 2 liters of ascites, do you still need to give albumin?
No, sir. It is greater than 3 liters to 5 liters. 3 liters to 5 liters we have to supplement albumin in order to avoid paracentesis-induced circulatory dysfunction.
No, I think you are confused. Up to 4 to 5 liters we can take without even giving albumin.
Okay,
after removal of 4 liters, still if you want to remove the patient's ascitic fluid, for each liter of ascitic fluid, you are taking 8 grams albumin.
Okay, sir.
Initial up to 4 liters you can remove without even giving supplementation of
Albumin. Okay, sir. So maximum is 5 liters or more chemicals you can remove, sir?
No, in large, what is large volume paracentesis? That's the question. Large volume paracentesis, removal of whichever fluid is there in ascites, we can remove entirely with the coverage of albumin. There is no limit actually. If you are doing albumin, there is no limit.
Okay, sir.
Do you know about INR? How do you calculate INR?
Sir, it is international normalization. So if we use a we use a standard ratio in lab, sir, to compare this prothrombin time. Not sure, sir, how would they measure that? There is a comparison ratio which is checked.
Okay. So basically, there's a formula. Na? You have to read that. They can ask you this. Okay, INR, na? It's actually the prothrombin time of the patient and the normal prothrombin time. Like denominator is normal prothrombin time, and it is the whole thing is squared to the sensitivity index. There will be international sensitivity index for that. That will be like different for each lab. So each lab chemicals have a different ISI ratio. So ISI score value actually. Usually it will be 1 only, but somewhere it can be 1.2, 1.3 as well. Okay, so it's so remember, read about that INR also. People are very fond of that. In my DNB, they asked me this question when I applied for the exam. That time.
Okay, sir.
Read about INR, LFT interpretation. So you should be aware of all those things. Okay, they can ask anywhere. LFT, ascites thing. Remaining, I think you answered. SAG,
Can
you
it be
answered.
alcoholic hepatitis?
Sir, it is AST ratio greater than by 2 times the ALT with AST less than 450, sir. And with alcohol consumption within the last 6 months is significant to label it as alcoholic hepatitis.
Good. You know the definition of alcoholic hepatitis.
Yes.
Yeah, I think you prepared well.
Yes. Thank you, sir.
Yeah, I think that's all from my side also. I think it was a good presentation. Okay. Well done. Okay.
Thank you, sir.
Will we join
I think we can end the session here.
Okay.
Okay.
All the
Thank you.
best, sir.
Thank you everybody for joining. All the best. Yeah.
Thank you, sir. Thank you, sir.